am so excited to have Steph Wagner here. She is a registered dietitian with 15 years experience in bariatric space. It started with patients who have undergone bariatric metabolic surgery and continues to do that as well, but also helps patients who are on GLP-1 and other anti-obesity medications. She has a membership program on her website and a lot of amazing free tools available. So I highly recommend that you check that out, and I'll include all the links below. But welcome, Steph. Thank you for being here.
Thank you for having me. I love seeing you, and anytime we connect and talk, it's always such a pleasure.
Yeah, absolutely. Well, let's get started. I will just start with a kind of basic question, but how can patients benefit from working with a dietitian?
Yeah, I love this question because, I hear patients say all the time, which makes sense, like, well, I know what to eat,
Mm.
right? Like, I know what to eat. And it's like, well, sure. I think any of us would pass that test, right? Like, if it was like, here's a grilled chicken breast and roasted asparagus, and here's a meat lover's pizza, like, we would pretty well know which one is healthier. I think my kids would know the answer to that. And I think there's a lot of places to go, whether it's online or even like the local grocery store, to get helpful nutrition information, how to eat at home more often, how to eat more fruits and vegetables. But when does a dietitian come into play? I think it's when things are starting to get confusing and complicated. So certainly when there's a chronic disease involved, obesity, and then there's also a lot of obesity related diseases. So if someone has obesity and the disease of diabetes, high blood pressure, or if we're starting to add even food intolerances or allergies, like all of a sudden things start getting confusing. Not to mention the things that come into life, like I'm trying to also feed my kids, or I'm caring for an aging parent, or I'm on the road a lot. And I think that is where a dietitian who specializes in both counseling and disease states in the body and how to make it all work for you, that's where I think it's worthwhile to work with someone that can really get in the weeds with you. That's my that's my go-to answer on dietitians. I have a lot of long answers about why dietitians are so great because I'm so biased. But anytime you feel confused and overwhelmed, that's a good starting point.
Yeah, absolutely. And I'm sure you've seen both, right? You've seen some people who are able to have maybe a few consultations and then some, work longer term with dietitians. So there is that flexibility as well.
Absolutely. I think that's a great point. And I think you could say the same is true with a mental health professional. You could probably say the same is true with like a financial professional. Sometimes, someone needs an accountant and they just need help, every once in a while with some basic tax things. Other times it's really complicated, right? And I think the same is true. I might see, like, I have patients that see me in the summertime because they're teachers and that's when they have time to really invest in that. And then they get into the school year and we just kind of touch base here and there, but mostly they're focused in on the school year. So it's totally dependent on the person and the place. Yeah.
Yeah, that's awesome. I love anything that emphasizes an individualized approach. And like you were mentioning, like a lot of this information, may be out there. You may be able to Google some stuff or ChatGPT or, talk to friends or, you've heard it before from other health professionals, but actually taking that information, working all the way through it, finding what actually applies to you, and then applying it to your day-to-day life, that is a whole other beast. And working with somebody who this is what they have trained in and this is what they do all day every day can be so efficient and make the process so much easier.
Yeah, absolutely. And I think a word on like access to dietitians, because you and I talk about advocacy a lot. If someone has private insurance, Blue Cross, Cigna, Aetna, who am I forgetting? United,
Mhm.
a lot of times under preventative care, you can get a dietitian visit covered at no cost out of pocket.
Yeah.
So I mean, pretty much my entire patient load is not paying for out of their pocket for these visits, especially with those insurance companies. Where it starts getting sticky and advocacy comes into play is if somebody is a Medicare recipient, then it's only with existing diagnosis of diabetes or end-stage renal disease or recent kidney transplant. So
Yeah.
you think about all the diseases that are left out, you know,
Yeah.
obesity, high blood pressure, cancer,
Mhm.
uh, eating disorders.
Mm.
So there is a bill that we're advocating for. It hasn't been reintroduced yet, but to expand that because, nutrition counseling to help, get patients off of medications and improve these disease states is so important. So I mentioned that because whoever may be watching this, it's possible you might have access to dietitians right now at no cost. Or if you're under Medicare, then you would have to have diabetes or end-stage renal disease, which can be frustrating.
Super frustrating for, those insurance types, but also very important to know, what to look out for if you have those types of insurance. And then if you do have private commercial insurance, that you do have that access and might as well take advantage of it. And like we said, it may just be that one initial consultation, or you may start a, long partnership with your dietitian.
Yep.
I would love to hear what your approach is for patients who have undergone bariatric and metabolic surgery, and then patients who may be on a GLP-1. Is it similar? What are the differences? Tell me more.
So those are such great questions. I think on a broad stroke, there's a lot of similarities because both of those are avenues to treat the disease, right? A surgical approach or a medical approach. And so nutritionally, we're going to be, kind of moving in the same goals of meeting protein needs, getting in fiber, staying hydrated, paying attention to what symptoms might come up, whether it's nausea, lack of appetite, lack of thirst. So the overarching goals are pretty similar, but I think where it starts to get a little bit, nuanced is um, in a surgical patient, things are really uh, maybe sensitive and fresh and new in that first 3 to 6 months, the first year post-op. And there's a lot of learning in that time, but the further out you get, maybe we're getting a little more comfortable with what's coming. Whereas in a medication, it's just a different progress, right? If you start the medication, you may not have a lot of symptoms right away. If you increase the dose, then you may have a new set of symptoms, or your symptoms might be different from someone else. And that's true with surgical too. But we might like in a surgical patient, we probably would move them towards solid meals for breakfast, lunch, and dinner, focusing on hydration in between, and maybe protein supplementation. But the further out they get, they probably don't need to drink as many protein shakes. Whereas with medications, there may be situations where someone does do a protein shake in the evening if they're having a lot of nausea, belching, discomfort because of that evening meal. So we might be moving more solid proteins and vegetables earlier in the day or kind of changing meal times or meal textures. So that's kind of unique to medication compared to surgery because they're similar and yet different. A protein shake in a surgical patient probably won't satiate them for very long because it's liquid based. It's going to move through their surgical pouch faster. Whereas there might be times where a protein shakes, we don't want to rely on it with a medication patient, but there might be times to manage their symptoms that it's the better avenue. And that's where working one-on-one with the dietitian can be really helpful to identify your symptoms, your hunger control, if you are having these other unpleasant side effects and how we can manage them through nutrition. How many patients maybe started a medication and didn't have nutrition counseling on their side, and maybe they discontinue medication because of symptoms. And it's possible those symptoms could have been managed through nutrition. So those are some of the answers. But I think as a broad stroke, the goals are pretty similar, but maybe how we get there starts to be a little bit different. But all that to say, if somebody was looking for recipes, a GLP-1 patient could look up bariatric recipes
Mm.
and find a lot of great recipes. So maybe that's just a hack to find meal ideas that would fit anybody. Yeah.
Yeah, great. Thank you for going over that. And really like that you highlighted the fact that, a surgical patient, they have a lot of change post-op right away, whereas somebody who is on a medication, we start at the lowest dose and then slowly titrate up as tolerated and as needed. And so it's a more gradual paced change, compared to that surgical patient. And then I also like that you highlighted if somebody maybe tried a medication in the past and didn't tolerate it for those, side effects, then it it may be worth, talking with your doctor and seeing if it's worth trying again alongside a dietitian to help with some of those side effects, which I think is really important because when you're able to build that team around you, you may have a very different result.
Absolutely. And let me turn that question on you. Have you noticed a difference if someone goes from a tirzepatide, for example, to a semaglutide? Are their symptoms noticeably different?
Yeah, sometimes, and I'll highlight one time that it's almost always different is if somebody tried a compounded version of a GLP-1 in the past, and compounded medications aren't regulated, so we don't know exactly what you were getting or exactly what dose, or maybe you were titrated too quickly by that provider. And so if somebody has tried a compounded version, then I am much more encouraged of trying a brand name version of the GLP-1s and that, we may have better tolerance. Um, Specifically for semaglutide and tirzepatide, the semaglutide tends to have more constipation and nausea on average. And then tirzepatide is more likely, if you're going to have a side effect, maybe like loose stools, maybe some queasiness. And so if somebody, had one or the other, then it may be worth, trying the opposite GLP-1 and seeing if you tolerate that one better. Because they're very similar, but there are differences and people do, sometimes tolerate one better than the other.
Yeah, that's great feedback. I've noticed that just anecdotally when patients mention they went from this medication to that medication and then are so surprised when the experience is so different.
Mhm. Yeah, yeah, absolutely. Um, and then I had another follow-up question with the difference between surgical and patients who are on anti-obesity medications. What is your approach to like vitamins and minerals and those sorts of supplements?
Oh, it's such a good question. I think in the world of weight management dietitians, we love trying to keep up with this stuff, which is really exciting. I'm a part, I'm a member of all these different groups to stay on top of the research. So we have a lot of great information and data in the surgical patients. So we know, each surgery, a sleeve, a bypass, duodenal switch, SIPS and SATI, which I'm abbreviating those. But we can really get detailed of like, this is exactly what they need for each of these vitamins and minerals. We don't have quite as much of that data with medical treatment with medications.
Mhm.
And I don't, you can't just completely apply the same things because there's not an anatomical change. There's not the same malabsorption that's happened with especially a DS, a duodenal switch, or a bypass.
Mhm.
But certainly, supplementing with a multivitamin is a great idea.
Mhm.
And I don't, maybe you can speak to what labs you like to check, but I think even that can be a little bit of a moving target about what labs are being checked.
Mhm.
So, dietitians, I think our field, our practice is growing a lot in the way of what we call nutrition focused physical exams, which is a way of being able to identify, whether it's through sight or through touch, if someone is showing maybe some signs of a deficiency. So there might be different questions a dietitian can go over, both with your food recall and what you're eating, and kind of identify if maybe there's some gaps there, but also if there's any other symptoms you might be experiencing. So it is helpful to let a dietitian know if you're having dry mouth or tingling of the hands and feet. And same for any of your providers. If you're having any symptoms that feel new or unique that you weren't having before a medication, you should bring that up because those could be an opportunity to say, oh, we need to take a look at what this lab might be. And not all vitamins are checked every time. I mean, that'd be incredibly expensive too, right? We can't,
Hmm.
we would
Yes.
love to be able to do that, but it wouldn't be fun for the patient either. B1 is a vitamin we watch quite a bit just because it's a really short half-life. So there might be situations where, depending on the patient and their intake, maybe we would add a B complex, or we would just look at what your multivitamin is bringing in. A lot of providers like fish oil. So it gets a little bit more nuanced to sit down with the medical patient and what they're eating and what their labs were prior to starting a medication. Whereas the surgical process is pretty buttoned up, right? We're seeing patients pretty consistently prior to surgery, checking a lot of labs prior to surgery, and then there's these routine follow-ups, and we've got really structured labs, structured vitamins to be taking. Uh, Whereas I think we have to get a lot more, um, you know, clinically involved in identifying if there's anything going on with a medical patient that maybe could get missed. And that's another situation where if you don't have a comprehensive team, something could get missed.
Yeah, I agree. It seems like we just don't know yet with the GLP-1 medications specifically. And I tend to recommend adding a multivitamin. If somebody is reducing the amount of foods that they're eating, we may not be getting all of the vitamins and minerals that we need, and we may not have even been getting them before with our nutrition. So it usually does not hurt at all to add that multivitamin. And then I absolutely want to repeat, yeah, if you're having any symptoms, especially that are new, definitely, tell your provider so we can look into that. Because yeah, we can't check everything. And so oftentimes it is symptom based. So definitely communicating that.
Yeah.
Um, I'd love to hear what your thoughts are about anybody who maybe has had a history of disordered eating or over restriction,
Yeah.
and how to approach nutrition planning or working with a dietitian in a way that is not triggering.
That is such a good question. I love that you asked that. I was texting with a personal friend last night whose specialty is eating disorders. She's a dietitian, and we talk often about our two worlds because you would think that they're not alike.
Yeah.
And yet we talk often about how similar they really are. And I really appreciate having someone that I can talk to. So I think some things to look for is when you're looking for a provider like a dietitian, probably do want to look for um, pay attention to things that might feel triggering. Ideally, it's a dietitian that isn't going to pull out a specific prescribed calorie count, especially if that's triggering. But that probably is a sign that this isn't going to be as focused on habits and lifestyle and disease management. This is a little bit too restricted and structured, which, there's just not a lot of great evidence that calorie-based eating is a great approach to treating obesity. Um, you could look for if a dietitian has, this is a newer credential, but a CSOWM is somebody that's more certified specifically in obesity management, and that's going to be someone that knows how to screen if there are eating disorders present. There's kind of different screening tools, just like most providers do. So while they're doing an intake, they might also be noticing you won't know that you're doing an intake form, but they might be kind of noticing if there is some, disordered eating patterns that they may want to refer you to a different specialty at that time. Because there's also a little bit of a difference between disordered eating and an eating disorder. So if someone has disordered eating, but we can, that patient and I can keep working through their other habits, and maybe there's things that they can do earlier in the day that set them up better for that time of day, and through that counseling and through that process, we can work through maybe triggers towards some disordered eating and change their thinking or their approach, or just feel more safe that they've got somebody to work with and talk through all this with. But if somebody is now like, no, this seems more like we're moving into a diagnosis of an eating disorder, then they probably should not work with a dietitian that's specializing in weight reduction. They may need to go work with a dietitian that's more specialized in that disorder and get true treatment before they can move kind of back into obesity treatment. It's a fine, delicate dance. I think we're all trying to figure it out. But there's that I was texting a friend last night because there was a book that somebody shared on this topic, and I was like, let's read it as a book club and make
Yeah.
sure that we're talking together as providers. How do we catch these patients? Because it can lead to really detrimental things. Yeah.
And it is such a fine line. And I'm sure you've seen on social media and just like working in this space that at times it seems like we can be like butting heads with obesity medicine versus like health at every size or eating disorder providers. And when you really look at what our goals are for our patient, like you said, they really overlap and align. And I think a lot of it is just kind of the maybe the terminology that we're using, or just I guess where we're starting from. I'm not quite sure, but I do think that having somebody in that space that you can work with and you guys can refer patients back and forth to each other, I think is so powerful because both are really important and both deserve treatment. And the same if a patient does have disordered eating or even an eating disorder and they have obesity, they deserve treatment for both if that is what they want. And then oftentimes it's usually that eating disorder gets treated first and then we can treat their obesity. So I've seen that in my
Yeah.
practice and it's gone very well for patients who had their eating disorder treated first and then come and see me after.
Yeah. That's so encouraging. I love that you brought up the topic. I've even had personal friends go see a physician for obesity medication, and it triggered their eating disorder based
Mm,
on a conversation with a provider, which we know is an issue, and that's, can be upsetting. So I think just kind of going back to your initial question, like if there are triggers present, just like in any other situation, find a different provider if it doesn't feel like a good fit. Because she ultimately took a year off and
mm,
went to a different provider, and it was a much better fit. So even as you're learning who your team's going to be, if
mhm.
you feel like it is triggering you into a place that is not a good fit for you, listen to that inner voice.
Yes, yes, yes. You know what's best for yourself. You truly do. And your physician and your dietitian and anyone else on your team, we're just helping provide information and help guide you. But yeah, you know what is best for you. So, we're always turning into yourself is important.
Yeah.
So last question, we talked about some barriers of insurance and maybe barriers of, disordered eating or eating disorders. What are some other barriers that patients might face to working with a dietitian?
That's a really good question. I mean, I think probably like so many things, if I went around like, who is it? Is it Jimmy Kimmel or whatever? One of those shows that had like on the streets. And I asked people, I have a feeling most people would just say time, if it's one more appointment to get to, or I work 8 to 5 and that's when their appointments are. So, I think that if that's a barrier, there are dietitians that will take evening or weekends. It's harder, of course, because most people don't want to work at those hours. But it's possible someone in your area or somebody online that's licensed in your state could take an off hour.
Mhm,
Or if it's a once a month check-in, maybe it's something you can start your day an hour later and take the first appointment of the day or take a lunch hour or whatever it needs to be. Thankfully, this is something that can be so easily done over telehealth, so you're not driving to a clinic to do it.
mhm,
Um, and I think maybe the other one is just to if there is any concern of feeling shamed
mhm,
of, it's a very vulnerable moment to come into someone's office or a computer and tell them what you're eating. I mean, that's a really personal conversation. So, um, just like any other provider, mental health provider, you do want to make sure it's someone that you feel supported, you feel like there's empathy and compassion, and you're being heard and listened. There's a style of counseling that dietitians are trained in, some more than others. We have to get a lot of continual training in it, but it's called motivational interviewing. And the idea is that in the questions I ask you and my listening and reflecting back to you what I heard, you can find your own goals. I didn't give you the goals because if I came in here and was like, okay, Lindsay, I want you to do this, this, and this, you'd be like, okay, great, right? But I told you to do it.
Yeah.
So if someone is truly trained in how to do this dialogue, where there's some education, but they're also helping you to find the words of what you're looking for and what your goals are, then there is research that says you're more likely to reach that goal because you made it.
Mhm.
So I can say that's very true. Usually through the right conversations, patients kind of solve their own problems, meaning, oh yeah, if I put my keys next to my water bottle in the refrigerator, I won't forget my water tomorrow. And they came up with that. I didn't come up with it as an example. So,
Oh, that's awesome. Yeah, I knew you were going to say time. That was the one that I was thinking and that I hear most often. But investing the time into our health is so important. And if it feels overwhelming and impossible right now, finding people like Steph and following them on social media and getting bits of information along the way. There's so many, great dietitians out there that you can start learning from. And then, if you're needing that step further, then, scheduling an appointment can be so helpful or joining your membership. I'm sure that that's a great way to go about it as well. And then thank you for bringing up the shame aspect because that is also so common in, the fields that the field that we work in. And finding that provider that is not going to shame you because it is not your fault and it is okay to keep, trying to find that person that is going to treat you with the respect and dignity that you deserve. So thank you for bringing that up as well. And just thank you for the time here. Do you have any last things to say, or definitely, share how people can find you and connect with you?
yeah, I will tell them how to share. I have one more question for you if we have time.
Yeah.
Um, Bariatric Food Coach is where you can find me on all the places, bariatricfoodcoach.com. Hundreds of free recipes there, blogs, lots of stuff, and then all the social media channels. I'd love to see you online there. Question to you is like I had a patient as an example that newly diagnosed with diabetes and they were seen with their primary care doctor, 21 years old, strong family history of diabetes, and they were given insulin and metformin,
Mm.
which in some ways I think that makes sense. Let's just get the blood sugars under control. But that was that's all the information that they were kind of given to start with. So for that patient, is it appropriate for me to say, why don't you talk to your doctor about some newer medications? Because I'm
Mhm.
thinking it's very difficult to lose weight if you're taking insulin. So we do want to manage diabetes, but we have other options available. Do I recommend an obesity medicine doctor or an endocrinologist? What would your take be on that?
Yeah, that can be such a difficult situation to be in. And I found myself in situations like that because I have a contract position where I see patients for a specific, condition, but I go over their history and sometimes, that scenario comes up. And I do feel strongly that our newer medications, our GLP-1s and our SGLT2 inhibitors, and our old medicine, metformin, are really the three best medicines that we have to treat type 2 diabetes. And patients should ideally be on those three. And I do think it's appropriate, to share that knowledge with patients. And I would start by having them ask their doctor about that. And maybe they did have a plan to just quickly or more rapidly reduce their blood sugar into a healthy range and then transition to those medicines. And that, like you said, may be appropriate. But I would hate them to continue on, just insulin and metformin when we have those other options. And so if their doctor was not planning on that or does not feel comfortable with it, then that would be a time to maybe get that referral to endocrinology or obesity medicine or another primary care doctor. But I think it's worth having a conversation about that for sure.
Yeah, thank you for your take on that. I'm like,
Mhm.
what would Dr. Ogle do?
Yes. All right. Well, yeah, thank you so much again for being here. I learned a lot, and I know everyone else will too. And I will definitely ask you to come back on in a future time to share even more.
Sounds great. Thanks so much.